So friends, after discussing the anatomy and the physiology of the nose and the paranasal sinuses, let us now discuss the disorders of the nasal septum. Okay, so first we'll discuss the medial wall disorders, then we'll go to the remaining nasal cavity and the paranasal sinuses disorders. Okay, so let's start with the nasal septum disorders. The number one, the disorder that we want to study is the septal fractures. Okay, let's say there are two boxers who are doing boxing. So boxing takes place in a boxing ring, we know that, but it's not a ring, it's a square. So that's a misnomer over there again. Okay, the boxing ring is actually a square with four corners, right? So now a boxing is taking place and each boxer is trying to punch the other one. So you see what happens, one of the boxer takes the punch and tries to land on the face. Okay, so when he punches like this, the punch goes and it lands on the nose, right? Now you see the punch is not going straight like this. It is going little bit from the side, right? So the punch will not land on the nose straight from the front. It always comes from the side. Okay, now what is there on the nose? We know the anatomy. The upper 1/3 of the nose, it is bony. The lower 2/3 of the nose is cartilaginous, right? The lower 2/3 is the mobile part. But the septum, you see, the septum contains the cartilage, but this cartilage is fixed. It is fixed to the bones, right? Now when you punch it like this, what will happen? It will break. It will break, okay? It will break away from the bone to which it is attached, right? What do we call it? We call it as jar-away fracture, okay? So that is jar-away fracture. Now what do you see in this diagram? You see over here, we have the septal cartilage, right? So this we have studied. We have the septal cartilage. Behind that we have over here the vomer bone, right? Now the fracture line is parallel to cartilage vomer junction, right? So you can see it starts from below. It is parallel to cartilage vomer junction. That is known as jar-away fracture. The punch or the blow comes from the side, right? Okay, now instead of punching like this, the boxer can also give an uppercut. Okay, so that's known as uppercut. Now, so punch comes and lands on the nose like this, right? So what will happen? Now the direction of force has changed, right? So let's say this is the septum, the punch comes from below and lands over here. Now what will happen? The septum will move like this, okay? So septum fractures like this, and now we have a fracture over here. You see, this fracture line starts from the anterior most point of maxillary crest. We call it as nasal spine of maxilla, okay? So nasal spine of maxilla, this is the anterior most point on maxillary crest, okay? And from here you can see that this fracture line, it goes up to the nasal spine of frontal bone, okay? So starting from the nasal spine of maxilla, it goes to the nasal spine of frontal bone, and this fracture is known as Chevalier fracture, okay? So this is known as Chevalier fracture. So remember, in case of Chevalier fracture, the punch comes from below, all right? The fracture line runs from spine to spine, okay? Spine of maxilla to spine of frontal bone, all right? So there are two types of fracture that we have studied. Number one was the jar-away fracture. The fracture line is parallel to cartilage vomer junction. Punch usually comes from the side. And the second that we have studied is the Chevalier fracture. Punch comes from below, and this fracture runs from spine of maxilla to spine of frontal bone, right? What else can happen when there is a blunt injury to the nose or the nasal septum? So number one we have seen is the septal fractures. Now remember, in the previous topic we studied about the blood supply of the nasal septum. We know that the septum is richly supplied by 5 different arteries. So there is a lot of blood supply. Okay, so what can happen? One of these arteries can rupture. Okay, so if these arteries rupture, there will be bleeding, right? So we know that the blood can come out from the nose, we'll have nasal bleeding or epistaxis. All right, now remember that this septum, we have the septal cartilage, right? So we have the septal cartilage. Now on the two sides of the septal cartilage, you see we have the perichondrium. Okay, so there is a layer of perichondrium on both the sides of the cartilage, right? Clear? So we have the, you see, cartilage over here. On the two sides of the cartilage, we have the perichondrium. This perichondrium is covered by mucosa. Okay, so this perichondrium, you see, on both sides, it is covered by nasal mucosa. So this layer together, it is known as mucoperichondrium. Got it? So this layer is known as mucoperichondrium. Now what happens? The blood supply is rich, abundant, and because of trauma, the blood vessels break down. So what can happen? The blood can collect between the cartilage and its mucoperichondrium. Okay, so the blood will collect between the cartilage and the mucoperichondrium, and we will have a condition that's known as septal hematoma. Okay, so this condition is known as septal hematoma. So what is septal hematoma? There is collection of blood between the cartilage and its mucoperichondrium. Okay, so we call it as mucoperichondrium because it is mucosa plus perichondrium. Right? Now, most common cause we have just studied is trauma, blunt injury. Now, how will this patient of septal hematoma present to us? Okay, how will he present? What do you see over here? There is a hematoma, it will block the nasal cavity. So the patient will come to us with complaint of nasal obstruction. Now, most important point, on which side will the patient have nasal obstruction? So remember, the septum is midline. Whenever there is a fracture, there is blood collection, okay, the hematoma formation is always bilateral on both the sides. So patient will have complaint of bilateral nasal obstruction. So that is important. Patient has bilateral nasal obstruction after an history of trauma, or let's say patient had a fall, patient was walking, or patient fell from the bed and hit the nose. So there is a blunt injury, that is also a kind of blunt injury, and patient will have bilateral nasal obstruction because of formation of septal hematoma. Right? Okay, what will we find on examination? On examination, when you look at the septum, you will see that the septum is swollen on both the sides. So as you can see over here, the septum is swollen on both the sides. Okay, so that means there is some collection between the cartilage and mucoperichondrium, which is likely to be blood. Now, what treatment will you offer to this patient? The treatment, we have to drain the hematoma. So the treatment is incision and drainage. Okay, so you have to do incision and drainage. Okay, IND, that is the treatment. But when you do incision and drainage, the bleeding is still there. So after incision and drainage, the blood will keep on coming out. To stop that, you have to also apply pressure. All right, and how will you apply pressure? You will do bilateral anterior nasal packing. Okay, so treatment consists of number 1, incision and drainage, and number 2, bilateral anterior nasal packing. Right? Okay, now let's say you do not do incision and drainage. The patient is not willing. All right, the patient does not present to the doctor. He is at home. He does not come to doctor. He does not want IND. What can happen to this hematoma? If you leave it like that, what can happen? This blood can get infected. All right. If the blood in the hematoma gets infected, we'll have a condition that is known as septal abscess. Okay. So you see, we'll have now septal abscess. So what is septal abscess? Septal abscess is pus. There is pus between the cartilage and its mucoperichondrium. Now the blood has been replaced by pus. Okay, so there are dead cells, there are macrophages, there are white blood cells, lymphocytes, leukocytes. So we have, pus formation between the cartilage and mucoperichondrium. So what will happen? Pus means pressure. Pressure means pain. Now patient will have severe pain in the nose. Okay. So you see, now patient will have pain in the nose, severe pain in the nose. What else? Of course, the pressure will lead to more obstruction. So patient will now have more pronounced bilateral nasal obstruction. So earlier, if the obstruction was less, now it will increase. So patient will have bilateral nasal obstruction. He will not be able to breathe at all from the nose. Okay, what else? Of course, there will be signs of inflammation. It will be red. It will be hot. If you touch it, it will be tender to touch. Okay, patient can have fever because of the abscess, especially in children. Patient may go into septicemia because of the abscess. Okay, remember this abscess is almost at the danger area of face. Okay, where is it? Near the danger area of face. If it spreads to the outer nose, it will be a danger area. So it can be very serious infection if we allow it to go further. Right? So what treatment will you offer for septal abscess? For septal abscess, once again, we have to drain the pus. Okay, so what will we do? We will, of course, do incision and drainage. Right? So we will do incision and drainage, IND. And again, once again, you have to apply pressure. So for pressure, you will do nasal packing. That will once again be bilateral nasal packing. So which packing you will do? You will do anterior nasal packing. Okay, so bilateral anterior nasal packing you have to do. Other than that, we have to give the patient systemic antibiotics. Okay, now systemic antibiotics, for the first few days we will prefer IV antibiotics. Later on we can convert into oral antibiotic, but we have to give systemic antibiotics. Okay, at least for 7 to 10 days, because we don't want any residual infection to remain behind. Remember, this is very near to the dangerous area of face. Okay, so at least, this I am saying at least, you have to assess the patient and see how much infection and inflammation is there. So minimum you have to give for 7 to 10 days. You can even extend it to 2 weeks or 3 weeks depending upon the inflammation and patient's response to the antibiotics. Right? So this is the treatment you will offer for septal abscess. Alright, okay. Next is what will happen because of septal abscess. So we have seen that the septal abscess, it is very near to danger area, and the danger area complications we already know it can spread and cause cavernous sinus thrombosis. But what is the most common complication of this septal abscess? The most common complication of septal abscess is septal perforation. Okay, so most common complication of septal abscess is septal perforation. Okay, so what happens in septal abscess? Because of the infection, the cartilage undergoes necrosis. So because the cartilage undergoes necrosis, now what happens? There is a hole created in the septum, that's known as septal perforation. So as you can see over here in these figures, you can see a hole over here. So that hole over here, and this is a very big perforation which we can see in the second photograph. So that is a nasal septum perforation. Right? Okay. What are the causes of septal perforation? Let's discuss the causes of septal perforation. Okay. So we'll talk about this septal perforation now. Now the first cause. Okay. Somebody asks you, what is the most common cause for septal perforation? Answer is trauma. Okay, answer is trauma. Trauma is the most common cause for septal perforation. Okay, now trauma can be of different types. Alright, trauma can be of different types. What can be different types of trauma? You can pick up nose picking. Nose picking is a kind of trauma. Okay, so if somebody repeatedly keeps on picking the nose, one day it will cause perforation. Alright, now nose picking, remember I told you in the chapter of epistaxis that nose picking is the most common cause for epistaxis. Which type of epistaxis? Anterior epistaxis. Okay, so I hope you remember that nose picking we talked is the most common cause for epistaxis. Now, question comes in the exam, is nose picking the most common cause for septal perforation? Answer is no. No. Why? See, the most common cause for septal perforation is trauma. Nose picking is only one type of trauma. There are other types of trauma that together contribute to making it the most common cause. Okay, so as I was telling you, nose picking is one type. Then we have penetrating injury. Okay, we have penetrating injury. All right, we have iatrogenic injury. Iatrogenic injury means suppose you do repeated chemical cautery. So again you are trying to damage the blood vessels, so that place may undergo necrosis if you put too much of chemical or repeated chemical cautery. Or iatrogenic injury may also be as septal surgery. Septal surgery is also a type of trauma. It's an iatrogenic injury. Right? So trauma you can classify into different types. Together all of this constitute to the septal perforation, makes the trauma as the most common cause. Right? Number 2, we just studied septal abscess. Okay, so remember, most common complication of septal abscess is septal perforation. Most common cause of septal perforation is trauma. Right? Okay, so that we have studied. Then what else do we have? We have septal piercing. Okay, so what do we have? We have septal piercing. So many girls, you have discussed earlier also that we have piercing on the nose, that is on the ala, right? But some girls, they also prefer septal piercing. Okay, so let's look over here. We know that the septum piercing, we have discussed it earlier, is done in the membranous septum. So remember, septum has 3 parts: columellar septum, membranous septum, septum proper. The membranous septum does not have any bone and cartilage, so that is the preferred place for doing a septal piercing. Okay, and this septal piercing is quite in fashion. It is traditional. Okay, many culture it is followed. Remember this movie. Okay, so remember we had a famous blockbuster movie, Bahubali, and all the women over there, they were wearing the septal ring. Okay, so this is followed as a tradition in lot of cultures also, right? What else can cause septal perforation? We have cocaine abuse. Okay, what do we have? We have cocaine abuse. So cocaine is a very strong vasoconstrictor, right? Now people who use cocaine, they generally sniff it. So when they sniff it, the cocaine constricts the blood vessels in the nasal septum, and that leads to necrosis of the cartilage, leading to septal perforation, right? Number 5, we may also have granulomatous disorders causing septal perforation. Okay, so we have granulomatous disorders which are causing septal perforation. These granulomatous disorders we can classify into 3 types. So what are these 3 types? Number 1, we can have those disorders which cause cartilaginous septal perforation. Okay, so which disorders cause cartilaginous septal perforation? We have tuberculosis, we have leprosy, and we have lupus vulgaris. Okay, what is lupus vulgaris? Lupus vulgaris is a mild form of tuberculosis. It's a cutaneous or skin tuberculosis, right? Okay, MCQ question that is generally asked in the exam. So remember, apple jelly nodule. So you can see over here, this is an apple jelly nodule. Now apple jelly nodules, they are seen in lupus vulgaris, right? So these apple jelly nodules you can see inside generally on the skin, cutaneous tuberculosis, but this if present on the septum, it can cause cartilaginous septal perforation, right? Okay, then other than cartilaginous, we have bony septal perforation. Bony septal perforation is caused by syphilis, right? So this is caused by syphilis. And number 3, we can have both bony as well as cartilaginous septal perforation, and this is caused by Wegener's granulomatosis. Okay, you have studied Wegener's in your pathology, and you know pathology and medicine that C-ANCA is the investigation, the specific investigation which is done for Wegener's. So Wegener's granulomatosis can cause both bony and cartilaginous septal perforation. Okay, now before we go ahead, just remember this thing that we studied about the cartilaginous perforation, tuberculosis, leprosy, lupus. All these 3 are caused by Mycobacterium. So the group causing cartilaginous perforation, it's easy to remember now, is Mycobacterium, right? Bony is caused by syphilis. All right, okay, so this question was asked in the recent exam, FMG, Foreign Medical Graduate Entrance Exam, or that's actually a MCI screening exam in August 2020. Syphilis affects which part of the nose? And the answer to this we have just studied. It causes bony septal perforation. So bony septum was the correct answer to this question. Okay, now in this topic we talked about septal surgery. So I said septal surgery is an iatrogenic injury that can cause the septal perforation. Okay, let us talk about the septal surgery. Let's talk a little bit about septal surgery before we finish the topic about the nasal septum. Okay, so septal surgery, there are 2 types of septal surgery that we have to discuss, SMR and septoplasty. So we must be familiar with these 2 terms, SMR and septoplasty, right? So what do you understand by SMR? SMR stands for submucous resection, right? So SMR stands for submucous resection. So we have to understand this submucous resection versus septoplasty. All right, let's look at this image of the septum. Shall we? Yes. Now, we studied about this septum. We have understood the anatomy. We know that this septum is formed by both bone and cartilage. Now, cartilage on the two sides is covered by mucoperichondrium. So, let's say this paper over here is the cartilage and the bone. Right? On the two sides, it is covered by mucoperichondrium. Similar to mucoperichondrium, the bone is covered by periosteum, and on the periosteum we have the mucosa. So the bone is also covered by mucoperiosteum. Okay, so we have a layer of mucoperichondrium and mucoperiosteum on both the sides of septum. Right? So we have these layers on both the sides. Now, what do we do in case of SMR? First of all, what we do in case of SMR? Now, in case of SMR, you give incision on the septum. Okay, so what do? You give incision on the septum and you raise the mucoperichondrial and periosteal flaps on both sides. So as you see, I have raised the flap on both the sides. Okay, what do you do in septoplasty? In septoplasty, you will raise the flap only on one side. So you can see the difference. Now I am raising my hand only on one side. So you can see that in case of septoplasty, you raise the flap only on one side, whereas in case of SMR, you raise the flap on both the sides. Okay. Now, next what you do? In case of SMR, what you do is, in SMR, you remove almost the whole bone as well as the cartilage. Okay. So you remove almost all the bone and cartilage, you leave only a L-shaped cartilage. So as I am drawing in this figure, you leave a L-shaped cartilage over here. Right? So you can see that this L-shaped cartilage which I have marked, you leave this L-shaped cartilage. This you will not remove. The remaining everything you remove, you try to remove maximum in case of SMR. Okay, so let's see over here. In case of SMR, you leave this L-shaped part over here. Okay, so you see this L-shaped part is left, the anterior most part, okay, which forms the dorsum, and the basal part which will give support, and you remove the remaining. Okay, so as you see, I have removed the remaining and I have kept the L-shaped part over here like this, and then you put your flaps back. So you see the flaps were raised and the bone and cartilage were bare, and you have removed most of it, left the L-shaped part, put the flaps back. So your septum is still there. Okay, this L-shaped part is to give support to the dorsum, the lower two-thirds of the nose. Right? Okay, so this is spared. Right? And then you put the flaps back. In case of septoplasty, septoplasty is a more conservative surgery. So what do? In septoplasty, you do not remove the entire bone and cartilage. You remove only the deviated part of bone and cartilage. Only the deviated part, not the entire part. Right? Okay. So septoplasty is a more conservative surgery. You see, you raise the flap only on one side. So when you raise the flap only on one side, you try to avoid damaging the blood supply of the septum on the other side. So you do not allow that the blood from both the sides should be hampered. So blood supply is preserved from the other side. Then you remove only the deviated part of bone and cartilage. Whereas in SMR, it's a more radical surgery. You raise the flap on both the sides and you try to remove maximum bone and cartilage. So now, which surgery will have more chances of septal perforation? See, after surgery, if there is an infection, there is a trauma, then SMR. You see, SMR is a more radical surgery. So SMR will have more chances of septal perforation. Okay, so remember, SMR is a more radical surgery. It has more chances of septal perforation. Okay, now there is one more concept. Please remember, okay, remember this point over here. This is the nasal spine of maxilla. Okay, this is the nasal spine of maxilla. This bone over here, we have studied. This bone over here is the nasal spine of frontal bone. Okay, now if I draw a straight line from the nasal spine of frontal bone to the nasal spine of maxilla, this line is known as Cottel's line. This line is known as Cottel's line. Yes, we have earlier discussed Cottel's sign that we discussed for the nasal wall collapse some time back. Okay, we also discussed that if there is a fracture along this line, that is known as Chevalier fracture. Okay, now this line is actually known as Cottel's line. Okay, now it has been seen that anterior to this line, if there is a septal perforation anterior to this line, it is more disturbing for the patient. Okay, it will cause more symptoms to the patient. It will cause more problems to the patient. If the perforation is behind the Cottel's line, like this over here, it will not cause much problem to the patient. Right? Okay, so nowadays there is a concept that ahead of this Cottel's line, you do septoplasty. Right? So anterior to the Cottel's line, you are supposed to do septoplasty. Behind the Cottel's line, you can do SMR. Okay, so that is the Cottel's line. Remember, what problem can this septal perforation cause? Because this can come as a clinical question. What problem can the septal perforation cause? You see, most problems are caused by anterior septal perforation. Alright, so as I told you, perforation can be anterior or posterior. Posterior are not significant. They don't cause clinical problems. Problems are caused by anterior perforation. Now, anterior perforation, you see, it can be of two types. Which two types? It can be a small perforation or it can be a large perforation. So we're talking about small perforation and large perforation. So this is a small perforation, this is a large perforation. Now remember, more problems are caused by small perforations. Large perforations are generally silent unless they become so large like this that the whole nasal septal support is gone and we have a septal collapse. Okay, in that case, we'll have a condition known as saddle nose. So remember, we discussed the condition saddle nose earlier in the external nasal disorders. So we'll have a saddle nose only when the septum cartilage is necrosed completely. We have a very, very big septal perforation. Okay, generally we do not have such a big septal perforation. Okay, so septal perforation, when I say, it can be small or large. The large ones, these perforations are silent, they do not cause much problem. The problem is generally caused by small anterior septal perforations. What problem can this cause? You see, the flow of the air in the two nasal cavities is a laminar flow. Okay, it's a laminar flow. But if there is a septal perforation, this flow is disturbed. And now it will crisscross. You see, it will cross to the other side. So now this will become a turbulent flow, right? Because of this turbulent flow across the septal perforation, number one, there will be production of a sound. There will be a whistling sound. Okay, now this whistling sound will be there whenever patient breathes the air in. And this can get disturbing to the patient, especially in the night time when the patient tries to sleep. So number one, the patient has a whistling sound whenever the patient breathes if there is a small perforation. Number two, because of this turbulent flow, there is dryness. Okay, there is crust formation. So around the perforation, there is crust formation. Okay, the mucosa dries up, forms a crust, and whenever that crust breaks off, it will cause some bleeding. Okay, so there is dryness, there is itchiness, there is crust formation, and because of that, there can be occasional nasal bleeding. So these are the complaints that generally the patient presents with whenever the patient has a septal perforation. Okay, and what treatment we will do for septal perforation? We'll try to close the septal perforation surgically. Okay, so nowadays we do endoscopic surgery. We lift the mucoperiosteal flap and we bring it over the septal perforation and we close it over there with the help of this mucoperichondrial flap. Okay, so we do a flap rotation surgery. This is generally done endoscopically. Right, now let's come back to the septal surgery. So we discussed about the types of septal surgery. Now we have to also know what are the indications for septal surgery. Okay, so let's talk about the indications for septal surgery. Now whenever I discuss about the indications, whenever I ask my students, the first answer that I get is, sir, the answer is DNS. What is DNS? DNS is generally the short form used for deviated nasal septum. Okay, and remember guys, this answer, deviated nasal septum, is wrong. Okay, now remember, deviated nasal septum, DNS, is not an indication. Okay, this is not an indication for septal surgery. Okay, why? I will explain it to you. Okay, now you see, the first indication for septal surgery is deviated nasal septum, DNS, causing nasal obstruction. You see, if we have a plain DNS, let's draw a diagram and try to understand this concept. Now, if we have a nasal cavity, and in this nasal cavity, let's say we have a DNS over here like this. Okay, or maybe we have a DNS like this. Is this a cause for surgery? Will it be an indication for surgery? The answer is no. Why? Because such a type of deviation is not causing any problem to the patient. Okay, remember, when we are born, nobody has a straight septum. Okay, you see, this nose, the lower 2/3 of the nose is made cartilaginous. Why it has been made cartilaginous? The nature has a reason for everything. You see, this is made up of, the tip of the nose is made up of elastic cartilage. Why? When the child is born, when the child goes, during the labor, the child passes through the genitourinary tract, to the pelvis. What will happen? The head is the biggest part of the child. So we know if the head passes, if the head comes out, the child is healthy, the child will come out. The child is safe. Okay, because head is the biggest part. Now, for this head to pass, the nature has done so many modifications. What it has done? You see our cranial bones, you see the parietal bones, the frontal bone, they have sutures. But when the child is born, at that time, these bones have not fused. So what happens? You see the sutures are not there, the bones, they collapse and they overlap, and the head is squeezed and it comes out. Same way, this tip of the nose has been kept cartilaginous, it has not been kept bony, so that it can also collapse in, so that it should not get stuck. So this nose, it collapses in. Because of the pressure it goes in. It's elastic cartilage. So when you are born, the nose has collapsed in, septum is deviated in almost 100% of the people. Okay, and what will happen? This cartilage will spring back. Alright, so within 24 hours to 48 hours, this cartilage will spring back. Okay, however, in 20% of the normal population, 20% of normal population still has some deviation throughout their life. The septum is not razor sharp straight. Okay, 20% of normal people will have some sort of DNS which does not require any treatment because it is not causing any problem. Okay, right? Now, when will it require treatment? When it starts causing some problem, such as number 1, nasal obstruction. So as you see over here, we can have a septum like this. Now you see this septum is blocking one side nasal cavity, right? So patient can have unilateral nasal obstruction. Okay, can this DNS cause bilateral nasal obstruction? Yes, it can also lead to bilateral nasal obstruction. Okay, how can it lead to bilateral nasal obstruction? There are two ways. One way is that this septum may be having a S-shaped deviation. So you see, the septum may be deviated like this. So this is a S-shaped deviation. So because of that, the obstruction is on both the sides. That is one way. It can cause bilateral nasal obstruction. Okay. Or the second way is that because of this deviation to one side, the airflow on the other side increases. Okay. Now because of increase in airflow, we have a Bernoulli's phenomena. The Bernoulli's phenomena means that the negative pressure increases, and that leads to the growth in the size of the inferior turbinate. Okay, so unilateral DNS can cause a compensatory hypertrophy of the contralateral inferior turbinate, and that can block the nasal cavity of the other side. Okay, so we can have DNS causing unilateral or even bilateral nasal obstruction, right? Okay, so in that scenario, we will need to remove or we will need to correct this deviation. Okay, if the inferior turbinate is hypertrophied, we will also need to do a surgery. We will have to reduce the turbinate. All right, we can reduce the turbinate with the help of surgery known as turbinectomy. In turbinectomy, you cut and remove the turbinate. Okay, or we can do turbinoplasty. Turbinoplasty, you generally reduce the size of the turbinate. So we will need to do a septal surgery along with turbinectomy or turbinoplasty and give a good patent nasal airway, right? So that was the first indication for the septal surgery that we discussed, that was the DNS causing nasal obstruction, right? Okay, what is the second indication? The second indication for the septal surgery is DNS causing recurrent epistaxis. So we know epistaxis is nasal bleeding. Okay, so DNS that is causing recurrent epistaxis. Now, how can DNS cause epistaxis? Okay, so let's go back and we draw over here once again this diagram, and you see sometimes we can have a sharp deviation like this. Okay, so we can have a sharp deviation like this. Now, this deviation can impinge upon the lateral wall and it can cause bleeding, right? This sharp deviation is known as spur. So what is spur? Spur is a sharp deviation of the septum. Okay, it is a sharp deviation of nasal septum, and it is generally found at the bony cartilaginous junction. So remember, it is found at bony cartilaginous junction, right? So this spur can lead to recurrent epistaxis. It may be impinging on the lateral wall, or let's say there is a vessel on the spur. Now, whenever there is an infection or mild trauma or dryness, this vessel can burst, or this spur can impinge on the lateral wall whenever there is inflammation, and it can lead to recurrent epistaxis. So in that case, we have to do a surgery and we have to remove this spur, this sharp deviation. Now remember, if this spur is touching the middle turbinate, now on the middle turbinate we have supply by anterior ethmoidal nerve. So that we have studied earlier, we have the nerve supply, the anterior ethmoidal nerve. Okay, so now if there is a touching of the middle turbinate by this sharp spur, it can irritate the nerve and we can have headache. Such a type of headache is known as contact point headache. Okay, so that is also possible. Okay, that can also be there if there is a spur, right? Remember, this pain may be referred to the front of the face. Okay, remember the anterior ethmoidal nerve, we have discussed in the physiology that it gives a branch, an anterior branch that supplies the dorsum of the nose, right? And so we'll have a pain over here. This is known as Slugger's neuralgia. Okay, Slugger's neuralgia is anterior ethmoidal nerve syndrome. So the anterior ethmoidal nerve is stimulated inside the nose. The pain is there, referred pain is there on the face, around the bridge of the nose, on the lateral part to the dorsum of the nose. That is known as Slugger's neuralgia, right? Okay, so let's come back to the indications for septal surgery. There are two indications that we have studied. Number one, DNS causing nasal obstruction. Number two, DNS causing recurrent epistaxis. And number three, we have DNS causing chronic infection. DNS causing chronic infection. Okay, chronic infection of the nasal cavity, that is rhinitis. How can DNS cause infection? Now you see, the DNS over here, if you see, the DNS leads to blockage of the nasal cavity. Even if sometimes it is not a complete blockage, it decreases the airflow. So if there is a reduction in the airflow, now what will happen? Because of reduction in the airflow, this side the secretions they accumulate. So because the secretions accumulate, the airflow is not proper, they get infected, and once they are infected, they lead to infection. Okay, and this infection does not clears out because the airflow is less. So DNS can lead to chronic infection, and to completely cure the infection, we may have to do a septal surgery and provide adequate airway. Okay, now other than these three, we can have two more indications for septal surgery. Number 4 is as a part of another surgery. Okay, so what do I mean as a part of another surgery? Suppose I have to do rhinoplasty. So remember, we discussed rhinoplasty much earlier in the diseases of external nose, and we talked rhinoplasty is a surgery of external nasal architecture. But sometimes septum is also deviated. So you cannot correct the external nose unless you correct the septum. So you may also have to do a septal surgery along with rhinoplasty. So as a part of another surgery. Okay. Number 5, we have to give access to another surgery. So what do I mean by giving access? Suppose I have to do a surgery on the sphenoid. So we have discussed that we can do surgery on sphenoid in the previous topics, and we can also go beyond sphenoid into the middle cranial fossa. Now, let's say that when we are doing surgery, the septum is coming in our way. We are not able to pass our endoscope or the instruments into the sphenoid sinus. Now, to make a space for this, we have to remove the septum. Septum is not causing any clinical sign and symptom to the patient, but for our surgery, we have to make space so as to we are able to do the surgery. So that means giving access to another surgery, to making space for another surgery. So we may also do septal surgery to give space or give access for another surgery. Okay, so these are the only 5 indications for septal surgery. Remember, generally the question asked is, which of the following is not an indication for septal surgery? And answer to that question is DNS, deviated nasal septum. Okay, now remember, the examiner may not give you word DNS. He may give you word over here, chronic DNS. So what do you mean by chronic DNS? Chronic DNS means long-standing DNS. Okay? Right? Is this an indication? No. Even if the DNS is for a long time, if it is not causing any problem, there is no need for doing surgery. Okay? Right? There is no need for doing surgery. The DNS may be since birth, as we discussed. Okay? So if the disease is since birth, what do we call it? We call it congenital DNS. Is this an indication? No. Again, this is not an indication. Okay? So chronic DNS, long-standing DNS, prolonged DNS, congenital DNS, all these are not an indication for septal surgery unless they are causing some problem to the patient. Right? Okay.